Thank you, sir. Now, I would like to introduce the next speaker of the session, Sir Anand M., proprietor of the Tech Medical Services. Sir has completed his Bachelor of Science in Bangalore University and Sir has been certified with the IBHRE and CCDS. Sir has been worked in the Andromed Healthcare and Sir has worked for the About as a service team head of Karnataka and a trainer at the About. I welcome you, sir.
In that I was just discussing with Anand also this time. There was this paper which was, we had this question in this last exam paper where it was mentioned about what are the parameters that you see in pacemaker programming. This came for the last question paper, right? For your paper. And this, I found 90% of students, I and ma'am have collected the papers. 90% of students have written how a pacemaker is done. The cleaning of axilla, this, that. That's not what we want. Parameters, the question was very specific. It's parameters. You have to know about impedance. You have to know about threshold. You have to know about what is sensitivity, what is yaw, what is lie, whatever. So the thing is, it's about a pacemaker. So some institutes which do not have exposure to it, this is particularly for them. Anand, I'm sure you'll do a great job. All the best.
Thank you, sir. Good morning. So today I'm going to talk about programming, pacemaker programming. It's very interesting topic and it's very easy topic though. And it's okay. Okay, so now we know where we have to give a pacemaker, right patient, right time and right indication, and strong evidence. We need to choose strong evidence to give a pacemaker to the patients, right? And up. So yeah, thank you. So when you give a pacemaker to the patient, it's not that it will not stop us, it will not end our job. So we need to take care of the patients in terms like regular follow-ups. It's very important. It's very important. That is our primary job, to take care of our pacemaker patients. It's critical and it's very easy. And technology, people think that pacemaker technology is very tough, but it's not at all tough. It's very easy. And I can say it is simple science, right? So let me go through some few slides. I have very short time, 15 minutes for me. So so stop me wherever you have the doubt, suppose. Okay, so importance of pacemaker programming. So we required a programmer to interrogate a pacemaker, right? So you can see there's a pacemaker, there's a band that we'll call it as RF telemetry band. Keep it on the pacemaker and then interrogate. So this will communicate from pacemaker to the programmer, whereas easily we can alter the parameters. We can change as physician suggestion. So whatever the required parameters can be changed. So, okay, what is our benefits? I mean, when you do the programming to improve our long-term outcome of patient pacemaker therapy, periodical follow-up is very important, as I told you, and to avoid re-hospitalization and redo procedures can be avoided, right? It's all in our hand. And patient safety and may increase battery longevity. If the patient is not coming to you after pacemaker implantation, it's very difficult. Pacemaker, whatever you have programmed, the higher voltage and all that, so it can drain pacemaker battery within 5 years or 4 years, or maybe even less also. So during the follow-ups, we can analyze where the parameter need to be changed, and accordingly we can do the needful for the patient. So we can increase the battery longevity also. And also the critical part is it can go loss of capture, over sensing. There are a lot of things which we are going to discuss further. That is going to be a patient safety. So what do you see here in this image? The single chamber pacemaker, which is VVI and VVIR, we will say that. So we will talk about that modes, what is VVI and what is VVIR as simple. So what we can see in the image, one lead, it goes into the ventricular chamber. So we will drop a lead in a ventricular chamber and we will pace from the ventricular right ventricular chamber, that we will say that VVI pacemaker or VVIR pacemaker. So let me rush quickly. So this is dual chamber pacemaker, which is DDD and DDDR. where it will maintain AV synchrony, that is DDDR pacemaker or DDD pacemaker, but definitely not single chamber pacemaker cannot be maintain the AV synchrony. And it's required two leads, one for RV, one for RA. So maintain AV synchrony, it maintains AV synchrony. AV synchrony, it will gives what? It is physiological AV synchrony. I mean to say, so natural pacemaker is dual chamber channel, right? Dual P wave followed by QRS. Here also, when you give a dual chamber pacemaker therapy to the patient, you can have really AV synchrony. Suppose I mean P wave followed by QRS, you can achieve. And also you can program a lot of parameters, heavy, delay, it's all in our hand. So what kind of parameters we need to program adequate for the patient to patient selection, we can do the needful. That is called AV interval, suppose. Rate responsive, anyhow, we are going to talk about. So rate responsive pacemaker, which is VVIR, it is rate responsive. DDDR also in the dual chamber rate responsive. So as patient physical activity demand, so we need to give pacemaker has to no, accelerate the rate as in needed, right? So if you put a DDD pacemaker or VVI pacemaker, the base rate has to be fixed. Let's say for example 60, right? So it'll pace at 60 only. Is that adequate for the patient? Right? If the young patients is receive the pacemaker BVI or DDD, if you program base rate at 60 or 70, it'll be fixed rate. If patient is doing activities like this, sleeping, sitting, walking, running, and or resting, so the all the way the patient rate will be 60 or 70, even the night and day, whatever. So here we need to choose VVIR, or at least we have to give him DDDR pacemaker. So let us see what is the benefit from this. And again, it's all about the programming. Rate responsive, just switch it on, switch it off. It's a one part of the things. It's one button, but make sure right parameters you are selecting as per the patient age criteria. You need to understand the patient history and activity level, and accordingly you need to choose parameters where medium, low, high, all the parameters is very carefully we need to choose. So then only it will supports for him as in needed. Whenever he demands for the rate, pacemaker will support as you program the base rate, right? Okay, so there are some modes. We will say that VVI, VVIR. Some people we cannot understand what is VVI, what is VVIR, what is AI, what is VVO, and all that. So this is something which we will call it as NBG codes. So NBG codes are 5. So the first line we can say that, let's say we will take it as DDDR. All right. So D, first D, we can say that chamber paced. So the D is chamber paced. This is dual chamber, either in atrium or in a ventricular. So it'll be paced. The chamber is paced. Then second D is sensing. The chambers are being sensed. If there is an intrinsic in the patient, intrinsic waves, so it can be sensed by the pacemaker. Pacemaker can sense. It is capable to sense. It can see the intrinsic activity in the heart, and it can inhibit the pacing. So that is what third letters talks about. So it's a response upon sensing, which sensing towards the second part, chamber sense. Whenever I sense, I should inhibit pacing, which means withhold the pulse. So that is what pacemaker does. That is DDD, right? Third D. So the fourth letter, rate responsive rate modulation, suppose, and fifth one, it is multi-site pacing, which is CRTP, CRTD, where we can say that multi-site pacing we can do from that. Right. Choosing a right pacemaker for your patient. How do you choose? How do you recommend? Let's say I need to choose a pacemaker. So don't go with the VVIR pacemaker. So most of the patients require dual chamber pacemaker only. As I told you, the benefit is AV synchrony. AV synchrony, we can maintain the PR interval. So a lot of algorithms, enhanced algorithms can be used in a dual chamber pacemaker. So it will mimic as in like natural conduction system, right? If you give a dual chamber pacemaker therapy. So single chamber pacemaker, yes, we do give single chamber pacemaker. So for certain patients, whereas atrial fibrillation, which is chronic atrial fibrillation, and atrial standstill. I hope this atrial fibrillation and atrial standstill, so which we need to learn, which we need to read and then understand. So standstill, there is no conductivity from the heart, right? So you can't pace it. And atrial fibrillation, of course, you can't pace. It's a fibrillatory waves. So you can't pace at whatever the AF. That's a chronic condition. We can't do that. In that case, we have to go with the single chamber in that scenario. Okay, pacemaker programming at the time of the implant. So what are the parameters we need to set? Let's say if I go for implant, so what are the parameters? I have the pacemaker, right? There are a lot of parameters which is automatic. I mean, it's already factory set parameters. It will be there. You don't need to do each and every. But there are hundreds of parameters are in the pacemaker box, pacemaker. So whereas you don't need to go each and every parameters you need to set. Certain parameters, which is safety parameters, can be programmed. That is very simple for us, suppose, right? So, and again, what are the simple parameters which we need to look in? Pacing rate. Maybe our physician may ask for this patient keep it at 80 or base rate during the implant. The moment of the time of implant, you may request us, so we can keep that. So pacing output with safety margin. So let's say, for example, the factory setting 2.5. So high threshold we found with the difficulty during the implant, and we may have to keep it at 5 volt or safety margin, double of the voltage we have to keep. So make sure patient safety with this margin only, safety margin programming is safe voltage only. So let's say now you have implanted, you have shifted the patient, and patient loss of capture, you can see the ECG. So that could be the top, below the threshold or sub threshold. We are going to talk about threshold, what is threshold, how to analyze threshold, how to find the threshold, and all that by so we will show through the programmer. So we'll go next, suppose. So post implant follow. So how do I take care of my patients post implant? How do I call the patient for the follow? So first follow up should be within the 2 weeks, 1 week or 2 weeks, and second follow up should be 2 to 3 months post implant. And programming of chronic output. So chronic pacing output means there is an acute space to pace to chronic pace, which means one day to, I mean, the post implant till 3 months, we will call it as acute, or 45 days also we can say that 45 days acute phase. So after 3 months, the patient, the leads will be set, thresholds and the voltage, everything will be set. We will call the patients already in a chronic pace. So in that condition, so we can confidently, let's say I got the minimum voltage required in the ventricular pacing is 1 volt. I can confidently keep it at 2.5 safety margin voltage. So that is how you need to analyze yourself and give the patient safety. And most important is patient safety here, right? So it's all in our hands, suppose. And every 6 months once should be okay to check the pacemaker. We can call the patient for a regular checkup rate. So every 3 months, when it is going to near ERI, we need to, let's say, 1 year battery. Okay, last 10 years battery longevity, and 9th year is coming for follow-up. We should not call patient for every 6 months or 1 year. So we should say that every 3 months or 2 months, we should call the patients, right, frequently, so that we can understand what is the battery longevity to give a replace the pacemaker. That's very, very important. And lifestyle. So we should not, when you are doing the counseling patient post implant, we should not misguide the patients. Most of the female patients I have seen in my experience, there's so much of anxiety after receiving the pacemaker. They think that it's a big, hard device where I should be take rest lifetime. Even the younger patient that does, actually, that's the wrong guiding the patient. So which we need to tell them, you are absolutely normal. There is no restriction for the patient, suppose much, right? Certain clinical parameters which we will, physician or implanter or physician will guide the patients, that should be much more sufficient. And we should not unnecessarily make panic patients, like don't go to office, or don't touch any electrical appliance and all that. You should not be guiding those patients. Some patients not even touch the mobile. They will not even switch on the switch because they are having the pacemaker. It may go short circuit or something like that. So in that case, we should give them the confidence, whereas they will carry the their pacemaker with peace of mind. They day and night. I mean, they can lead a normal lifestyle. Okay. So pacemaker programming during the follow-ups. So this is very important. During the follow-up, it is not during the implant. It's during a follow-up. What are the parameters which you need to look? So we need to check thresholds, impedance. So we will show you again through the programmer what are the nominal parameters which we required for this. during the follow-up parameters. Okay, here maybe you can see the smaller values. I mean we may not be able to see or read, but definitely we'll show with the programmer so that we can understand. So when the patient comes to me, first thing I will see that patient, I'll go through is first step is like take the patient file and understand what is the indications. As sir said, rightly said, so what are the indications? Why he has received the pacemaker? That's very important to understand, which you don't know. Let's say the first time you are seeing the patient, right? And you are going to interrogate the patient. So make sure your patient history is mandatory and obtain the ECG. What do you mean by what do you mean by that? So you should understand the patient ECG. Is it pacing? Is it a one spike, two spike? What is happening with the ECG? If it is not pacing, what is happening with the patient? When it is implanted? What was the previous report? And what was the parameters been set previously? Is it patient is okay or any symptomatic? All that we need to understand before we interrogate the patient. Let's say the patient has come from, for example, from outside. First time you are seeing maybe 10 years old pacemaker, and you are straight away you should not be keeping a band for interrogation. There will be a certain, I mean, maybe one or a few days of battery life. If you interrogate, it can go off also. Then patient may arrest, or if the escape rhythm, if it is present, then patient comes with the goes with the CHV. So understand all these complications. Make sure it's all in your hand how to take care of the pacemaker patient during the programming. It's very important thing actually. So as per physician suggestions, we should always take their inputs, and then accordingly we need to do the parameters settings. Okay, very important nowadays. All pacemakers are MRI compatible pacemakers, right? All pacemakers are MRI compatible nowadays. So we when the patient, which means patient can go for MRI scan, right? 1.5 Tesla or 3 Tesla as per the patient pacemaker, they're eligible to take the pacemaker scan, MRI scan. But let's say now it's MRI compatible. It doesn't mean that the patient can just walk in for the scan. No, we have to take the programmer and interrogate and do some settings, safe MRI settings. Accordingly, patient can get the scan and get it done, right? So these are the parameters, very simple parameters. You just go to the MRI settings, and you can see all the parameters automatically. It just pops up, and select the MRI enable option, and you can program. Right, once you program, and then once the MRI scan is done, so you can go back to the end session, and it will resume back to the exit MRI settings. It will resume back to the normal parameters, whatever the previously you have programmed. Right, so it's very simple. Do this so that patient, so why we should do that? See, these are all parameters where I can manually we can do that. No, we should not be doing this, because the pacemaker has the component, something called as a reed switch component in the pacemaker. When the patient goes for an MRI scan, inside the MRI scan, that because of the MRI field, magnetic field, the device thinks that I am in an MRI zone. So it will switch to the reed switch. It will switch to, it will thinks that it's the reed switch. It becomes on, which means the pacemaker thinks that I am in a MRI zone. So no complications will happen during the MRI scan. Let's say now non-MRI pacemaker, where same parameters I can manually program. So if I send that patient, there is no reed switch, pacemaker still think that I am not in MRI zone, right? So pacemaker can give asynchronous pulse. Blindly, it can throw some pulse. It can go RNT, and it can patient can during MRI scan, patient can get into VTVF, and those are the complications which we need to care, which we should be careful. Okay, post implant complications. So these are the very important points: lead dislodgements, loss of capture, loss of output, undersensing, oversensing, infections, lead coil break, lead insulation break, sudden Brady depletion. So these are the main very important points which we need to understand, which we have to read this and understand. Make sure this is very important with the pacemaker topic. Right. So few things which we will also go through. So loss of capture due to the increase in threshold. So increasing threshold can also not only the dislodgement or due to other things, it can some cardiac drug also can increase. So in this, I think flecainide is one of the most the drug can increase the thresholds. right? So we should be careful. I think physician will guide us. He is under placonite, so we should be keeping higher voltage. So these are the things which we need to monitor, right? And do the needful for the patients the right way. So loss of sensing, of course, there are because of MI and lead displacement and lead fracture, insulation break, and all that. Because of that, loss of sensing and over sensing can happen. Over sensing due to electromagnetic interference. So EMI. So mainly we can see EMI during a surgery when the pacemaker patient goes for surgery. We should change. We should change the mode into the DOO. I think modes I didn't cover the DOO. Suppose. Let's say VOO or DOO. What is the first D or V stands for? Chamber paste, right? So if it is single chamber, V, which is chamber paste. And whatever OO, nothing, zero, right? Nothing. It doesn't sense, no response to sense, which means one little paces, which means what pacemaker does? Blindly, it stimulates, throw the impulse to the heart. It is whatever you program parameters, which is 60 base rate or 70 base rate. At the base rate of whatever the rate, it will maintain the pacing only. So why I should choose this VOO mode during the surgery? Because when they use the cautery, right, to cut the tissue or coagulation, whatever. So in that case, we should keep VOO so the pacemaker doesn't sense electrical stimulus, so that it will not be inhibiting. So whenever it senses, or if it senses electrical cautery stimulus, it will think that there is intrinsic waves and it will inhibit. We'll see later in the ECG suppose. Okay, what is this ECG? You can see here. I'm not asking about what is this ECG. I can say that you can see this is a pacemaker pacing ECG. So you can see here one spike, right? And there is two spikes. So, oh, sorry, I do have. Sorry. So this is one spike, right? And in this ECG you can see two spike, right? So what do you mean by that? Is a single chamber and dual chamber. Is that correct? Right? Right? So he says it's a one spike. I will call this as single chamber. Here two spikes, so that I will say that it's a dual chamber. No, sometimes right, sometimes. It's one or two slides. One or two slides. What is it? A phase and B cells. You could or you may not have it. What if it really disturbs? What is the other thing this law? That's what. So it's not always. That's what Anand is telling you. So yes, so it is not always. It's a dual two spikes. So it's a dual chamber. Yes, when you see two spike, it's a dual chamber pacing. And what you need to understand is here. Sometimes where the one chamber it will be sensed and other chamber it will be paced. One chamber it will be paced and other chamber will be. So if it is CHB, I don't want to pace in atrium. I'll be sensing only, right? Pacemaker will be sensing and it will always pacemaker will be paced in ventricular, right? So in this condition, and one more thing which is very, very important, which you need to understand when you take the pacemaker ECG, you can just like that, you can say it's a single chamber pacemaker pacing ECG, it's a dual chamber pacemaker ECG, not based on the spike again. So you can see here AV dissociation in single chamber, always single chamber pacemaker ECG, AV dissociation, right? No relation between the A and V. That is single chamber, to be clear. And this is always gives dual chamber pacemaker, as I told you, always give A followed by V, which means P followed by QRS. So the AV association always presents. Okay, that is the key point. So here it's a question for you. What is this? If somebody can tell me this is what pacemaker it is, single chamber or dual chamber, and why it is some gap between here, and if somebody says, I'll be very much appreciate.
Yes,
So what
someone
is
take it
happening
up.
here? This is single chamber or dual chamber by saying 1, 2, 3 this intervals.
Anyone, one person, take it up.
Quickly. A simple question. Well, see, I could see one spike here, just onset of the QRS, and P there is no spike. So which means the pacemaker is sensing in atrium and ventricular it is pacing. So and it is regular. AV association is there. See, AV. It's clear. So which means it's a dual chamber pacemaker. And see what has happened here. No pacing spike also here after the P wave. So which means what is happening? So there is a what? Loss of output. The pacemaker sensing something, it's thinking that there is an intrinsic. It could be a lead noise, or it could be insulation break, or lead coil break due to some reason. Even during the surgery, if you are sending the patient with VVI or DDD mode in the synchronous mode, so you can see this kind of missing beats, or you can see some pauses, inhibiting pacing. So this is something we'll call it as loss of output, right? Okay, what is this then? What is happening here? So again, you can see P followed by QRS, P followed by QRS. It's a dual chamber pacemaker. Then what has happened here and here? Why there is a big gap? There is a spike. I can say there is a spike supposed to be QRS to be generated. What do you think? So it is not capturing, right? This is not capturing. This is a loss of capture. So probably the threshold might have jumped up due to some reason. So threshold might have high. So that's why it is a loss of capture seen here. So make sure if there is a spike and there is no QRS and then loss of capture, and there is no spike, but there is a inhibition, and which we need to say it's a loss of output. So take home points. So we're going to end this. So understand the patient clinical condition before interrogating. So that's initially I told, choose the appropriate algorithm as per the patient indication. So there are beautiful algorithms where it's sudden brady response, AF suppression, and AV search and all that. So which is right patients. We need to choose right algorithms in a pacemakers and program. We should program. So that is in our hand, suppose, and choose the appropriate parameters based on the patient clinical condition. So parameters also is very important. AV delay, just like that, you can't keep it at 200 or 150 or something like that, fixed AV delay or something. We should also keep rate response AV delay and all that. So and again, quality program brings patient better outcome. This is, I believe, always quality when you have knowledge, when you learn everything, you have knowledge, and quality programming always it comes automatically. You can do that and do the needful for the best. Thank you.
Thank you, Anand. Thank you so much.
I think
It's a very exhaustive talk.
so we'll not take questions now.
Yeah.
If there are any doubts in the lunch break, you can ask, because we're running short of time.
And the other thing is, this goes also into ICDs, which I think part of it, of course, we gave you much less time, but read about ICDs also and read about CRT programming also, in case it will be asked for you. These questions sometimes are asked, or they can ask as a 5-marker. There is some in the pool, they put impedance, they put threshold, they put all of those separately. So please take that into consideration also.
I'll just take 2 more minutes just to show interrogation. Okay, so they will help us how to interrogate. So let's say if once I interrogate, so this is the programmer where we can see the screen, right? So that's the top is ECG. We do have the programmer ECG. We can give proper 4-channel ECG, and we can say that it will EGM, IEGM, that is intracardiac signals, because we have the access pacemaker to the chamber, right? So atrial signals and ventricle signals, intracardiac signals can be seen by the programmer. So that is the beauty where we can easily understand what is happening with the pacemaker and what is happening inside the heart, really, right? And also the markers which pacemaker gives us to understand better, right? Whatever the pacemaker does, it will annotate here. So saying that let's say A sense is atrial, I'm sensing in atrium, V sense is I'm pacing in I'm sensing in ventricular. So it is very important. And also we can see there is the interval 227, 223, all this the values which is PR interval, A to V interval, right? So once you interrogate, that's a main fast summary where you can understand better battle longevity, and also alerts. If any alerts we can open and you can understand, and basic parameters we can, once you go into that box, you can understand all that. So these are the basic parameters which you need to program. Mode, it could be rate, or all this we can choose, suppose. right parameters we can change. Okay, go back, go back. Okay, so make a note. Its impedance always should be 200 between 2000. It's very important. Okay, that should, if it is less than 200 or less impedance, that could be the, that could be related to lead current break. Okay, so that insulation break or insulation damage, whatever way. So in that case, we can see less impedance, and high impedance always it's a conductor fracture where there is no conductor flow. I mean the current flow. So in that case, we can always say that high impedance can cause suppose. So it is the normal range of impedance. Yeah, you can. Is it? So sensing parameters, P waves always acceptable. P waves always it's a more than 0.5 millivolt can be acceptable, and during implant always more than 1 millivolt is acceptable parameters, and during follow-up more than 0.5 can be manageable. It's acceptable parameters, and anything in R wave more than 2 millivolts is acceptable. During the implant more than 5 millivolt R waves is very important. So because these R waves, based on these R waves only, the as you set the sensitivity in the pacemaker parameters, you can always the pacemaker always do the right job. So you can see that's a patient intrinsic rate. It is doing extremely good job where it's sensing in chambers and inhibiting the pacing. Unnecessarily it's not pacing there, right? So that's what it's giving, suppose. Okay, close. So you can see this is the capture parameters where if you go to ventricular capture test, go to VVI. So some rate we can choose, and I need to understand what is the pacing threshold here. Threshold means the minimum voltage required to stimulate the heart, right? So here, so he is what is he doing? I'm just pacing in ventricular chamber and the single channel and finding where is the loss of capture. So there is a output where 1.2 it is captured. There is a 1 volt, it is loss of capture. It's paced. The VP is below marker is ventricular pace. It is paced. The pacing followed by there is a QRS, and loss of capture. It's very important to understand. You guys should go to and follow-up patient real-time interrogation and understand yourself. You have to hands-on you should get, and few programming if you do, you can understand easily better, suppose. Yeah, go. Next. So atrial threshold is the same, and alerts. Go back, go back. So you can see there's a percentage of pacing. A pace is 11%, V pace is 24%. So always you can understand, okay, this patient intermittent AV block would be the, so that's that would be the indication. So that's why the less percentage of whenever it's needed. So the pacemaker is supported. Otherwise, so remaining time, so it is always pacemaker is inhibited the pacing. So which means its patient has his own intrinsic. There are algorithms where you can use to promote the intrinsic also. Unnecessarily pacing also can be avoided when it's needed. Accordingly, the pacemaker can support that. We can do that. So I think we will end this because time is not very short. So we will close this. Thank you so much.
Okay, thank you, Anand.
Thank you.
Some other questions which are asked also to you is, which is the most physiological pacemaker? Anybody? Which is the most physiological pacemaker? Some questions asked in practicals are these. AAI, because it will be like a normal sinus rhythm. Sinus beat gives it, here your atrium gives it, atrial lead gives it. Short of that, EDDR. Then the second thing you are asked about in one paper, it was asked was hysteresis. You know what is hysteresis? Anybody can tell me? What is hysteresis? Anybody? You wait for the patient's intrinsic to come up. You keep 60 rate, but you give a hysteresis of 10, you make it 50. So you allow the patient's thing to wake up. It doesn't wake up, then you give the impulse. It's a technique of decreasing RV pacing. The less you pace,
because it's a short note sometimes.
it has been asked in 2013 or 14 months. Okay. Then another point was about ICD can pace and shock. Pacemakers cannot shock. If your patient needs an ICD, he can pace and shock. It can pace and shock. Pacemakers cannot shock. ICD can pace. Okay, this thing is asked. CRT was, CRT is a different ball game. CRT might be asked to you. I think this year or the previous year it was asked. Anything else? Questions with them? I think it's there in the pool. All these are there in the pool. It can be asked what you described very nicely. Thank you, Anand. Was about impedance. I told you threshold was asked. Slope was asked once. Then settings of pacemaker have been asked. 5 markers, 3 markers. I think we can go ahead. Thank you, Anand. Thank you so much. I just request ma'am to give him a small